You did. Welcome everybody to this year's Sokolow lecture. And as we were chatting about the very first hybrid grand rounds where we have our speaker in person. So we're exciting. This lecture is named in honor of Maurice Sokolow, who was the first chief of cardiology at UCSF until 1974. Soki, as his friends and colleagues called him, was part of the UCSF community from 1936 until 2002 when he passed away. He was a product of UCLA and UC Berkeley and a graduate of UCSF Medical School in 1936. Except for brief stints at the New England Medical Center and Michael Reese Hospital for residency and fellowship, he spent virtually his entire career at UCSF. Among his many contributions, Soki was a founding member of the UCSF Cardiovascular Research Institute, merging clinical cardiology with academic and research work. He was a creative researcher and teacher. His research focused on hypertension. He designed and developed the first ambulatory blood pressure device and was responsible for describing white coat hypertension. It is my pleasure to introduce this year's Sokolow lecturer, Dr. Mora. Dr. Mora is a cardiovascular medicine specialist at the Brigham and Women's Hospital, where she is, I guess now called Mass General Brigham, where she is the director of the Center for Lipid Metabolomics. She has joint appointments in the Division of Preventive Medicine, Cardiovascular Medicine, and Women's Health. Dr. Mora received her undergraduate degree from Harvard and her medical degree from Harvard. She completed an internal medicine residency at Mass General Hospital and cardiovascular disease fellowship at the Johns Hopkins Hospital. She left Boston, I guess, for a brief period of time. And at Hopkins also received a master's in health science epidemiology. She is a fellow of the American Heart Association, the American College of Cardiology, and the American Society of Echocardiography. She also serves on the editorial boards of JAMA Internal Medicine and the journal Atherosclerosis. Her clinical interests include cardiovascular prevention, lipids, modifiable risk factors, and women's health. She's the author of over 150 peer-reviewed publications. Most of those focused on her research area of risk factors and prevention in cardiovascular disease. Today, we're fortunate to have her be here in person and talk about primary prevention of ASCVD, where we are in 2023, precision medicine or population health.
Thank you very much, Dr. Ogun, and thank you everybody for this invitation. It's really a great honor for me to be giving the Sokolow lecture and also to be here, both physically and virtually with you all. These are my disclosures, nothing really particular related to this talk.
One moment.
Is better? I can't hear.
No, we're not being able to see the top.
On the slides. Should I then join the?
I'll do it here.
Yeah, thank you.
So these are again my disclosures. So as Dr. Owen was saying, Dr. Sokolow has many impressive credentials. He's the pioneer in hypertension and led to many numerous contributions for both ambulatory blood pressure, but also the ECG criteria for LVH, the Sokolow Lion criteria, which is the SNB1 plus the RNB 5 or 6 more than 35. But I was most touched by the fact that at age 6, he spent 7 years in an orphanage after his mother's death, and both he and his sister were actually in this orphanage for 7 years. So it goes to show you, one learns from these remarkable people how, despite all the adversity that they face, how one can really still not just surpass and overcome the adversity, but also shine. And I think the picture there I found online with his daughter on the left and his wife on the right, who unfortunately both died prematurely. And so there was also special lecture for them as well. And he was also a editor for Clinical Cardiology textbook. I also want to thank in particular Rita Redberg. Dr. Redberg has been my mentor, sponsor, and friend over the years, and I really appreciate all the mentorship and sponsorship that we were just discussing actually with the team here. So objectives of today's talk, first I'll review the current challenges for ASCVD, atherosclerotic cardiovascular disease prevention, and there's a lot of challenges for us. Number two, discuss some approaches. One is population health, which is taking more of a population approach to prevention, and the other one is more precision medicine, which is more individualized. Like let's try to get the, as individualized assessment of risk, for example, as we can. We'll discuss some of the lifestyle strategies, lipid and metabolic signatures of risk, and also discuss about a shared decision-making approach to aspirin used for primary prevention versus a polypill approach. So first, challenges. So these are some of the leading causes of death. As we know, cardiovascular disease remains the leading cause of death, both back like in for now like several decades. But in addition, if you look at the bottom of this graph, what you can see is that dietary risks, high blood pressure, tobacco, basically lipids, all the cardiovascular risk factors plus air pollution, which we actually know now also is related to cardiovascular disease, and low physical activity. These are all really cardiovascular risk factors, but these here are the top causes of all-cause death. So you can see how important cardiovascular risk factors are, not just for cardiovascular disease, but for all-cause mortality. And unfortunately, over the past decade or so, they really haven't budged much in terms of the risk. Like blood pressure went from number 3 to number 2, but otherwise no significant change. And in terms of overall CVD deaths in the US, they've actually gone up recently. These are total number of deaths, and you can see over the past few decades since the 1980s, because of the introduction of all the interventions, but also all the preventive therapeutics, we basically had quite a significant reduction in absolute cardiovascular deaths, and then they've been basically going up over the past decade or so. And then this last blip here was from COVID, or around the time of COVID. But even before that, you can see there was a trend, and that's in both men and women shown in red on the slide. That's in the US. Now you may ask, well, how does that compare with other countries? So for example, if the US here is in blue, the blue bars, men on the left and women on the right, you can see that we have quite high rates. These are rates per 100,000 in population. For example, the one next to it is Australia. We'll skip the third one because that's the Czech Republic. But after that, you see Germany in this orange, and then Spain. So these are European or other Australian sort of, economies that would be similar to the US economy, have much lower rates of cardiovascular death rates. So I think that's a key point, that there's a lot that we need to do better, and we need to figure out new approaches for that. This is a summary slide that I like because it discusses sort of primordial, primary, and secondary prevention. So today's talk will mostly focus on primordial and primary prevention. Secondary prevention, once people get the disease, is really a small part of the effort, but really a lot of the major effort should really be in primordial, which is the most important, where you have social determinants of health, and also health policies that impact all of us, not just for cardiovascular health, but also for health in general. And then here you're trying to prevent the risk factors from developing, and we saw that the cardiovascular risk factors are actually also the leading causes of death for all-cause death as well. So the two approaches that have kind of, there's a little bit of tension between these two approaches, because on the one hand, you have this precision medicine camp that people feel that, okay, the more precisely I can get all kinds of information, and I can individualize the profiling of somebody using, say, omics or as in-depth phenotyping as we can, that's precision medicine. And then on the other hand, there's the population health, which is, well, let's just budget the whole health of the population a notch down, or a notch, improve it a bit. And if you improve it even by a small step, but you're doing that on the population level, you're going to be able to get big impact, like big bang for the buck, because you have such a large number of people. And these two approaches, I would argue, are actually complementary because you need both. Precision, there are people always going to be at the also extremes that don't fit into the general population profile. But of course, if you also improve the overall population health, it's going to spread to everybody as well. And this is a nice article that summarizes some of the more modern kind of, both in terms of deep learning, deep phenotyping of individuals, whether it's omics or whether it's using AI approaches. I mean, this is really happening already now, and that's going to be the majority of evidence-based medicine, versus at the very top, you may get like some of the randomized trials you see here in green, like going to be a much smaller contribution in terms of the evidence base for like, this next generation medicine. So just to show you that there's a lot of change in this area in prevention, which is really tremendous. I mean, we would never have predicted that 20 years ago. Today's take-home points are that for population health, lifestyle changes should really be addressed at the population level and should begin early and underlie all our preventive efforts. On the other hand, for patient-centered or more individualized care, risk stratification is the key, and then matching the intensity of the intervention to the level of the individual risk. So we'll discuss first lifestyle strategies. These were the 2019, which are now like a few years old, but these are the most up-to-date ACC/AHA prevention guidelines. I just want to highlight that of their top 10 take-home messages, 7 were about lifestyle. And that's for a reason, because it's really important, but 7 of the top 10. The other 3 were 1 on risk assessment, 1 on statins, and 1 on aspirin. For primary prevention. And these can be summarized in the nice AHA Life Simple 7, which we're all very familiar with now. But just to show it for you here, it's basically the standard risk factors. Get active, eat better, lose weight, stop smoking, control the cholesterol, blood pressure, and sugar. Now, we did a study across the nation as part of this health assessment program, and we found that one of these risk factors track together. So birds of a feather flock together. And turns out in the study, we looked at couples. The average age was in the 40s. And in their 40s, from a variety of socioeconomic variety of geographic locations. But what we found is health and lifestyle changes, risk was actually the worst compared to all the other risk factors. And concordance, there was a high concordance of risk factors across the board. So 80% concordance of either ideal category or non-ideal category was high, but this 80% was for non-ideal category of the AHA Life Simple 7. So suggesting that, and this is just an average population part of a routine health screening for a company. So the rest of the risk factors, you can see we've done really well for cholesterol, smoking, we've actually done a decent job. But for physical activity and diet and the more lifestyle-driven changes, these are really still a huge challenge. And why is that important? Well, in this study from several of the landmark cohorts in the US, you can see that cardiovascular health, as for example, shown by here, the AHA Life Simple 7, was really strongly related to lifetime risk of ASCVD. So if you reached already middle age, which is I think now a lot of us, unfortunately, or at least fortunately, but if you reach middle age at age 40 to about 60 here, and you were followed after that for about up to 40 years, you can see that those with the worst scores on the AHA Life Simple 7 had really the highest risk of developing lifetime risk for CVD. And right now, this is really kind of one of the only ways to assess lifetime risk, is to count up the number of risk factors pretty much and see where they fall in these in their risk. But there's approaches ongoing to try to get lifetime risk more phenotype. But basically, it does correlate a lot with the standard risk factors. And that's regardless of race, ethnicity, as well as gender. And AHA Life, essentially, they added sleep as a component. So now we also have to worry about getting enough sleep, which is, of course, very hard to do. But sleep is up there because of the data, emerging data. And also for smoking, they also added e-cigarettes and secondhand smoke as an update. For diet, the US dietary guidelines, I recommend 3 beneficial dietary patterns: the healthy Mediterranean style pattern, the healthy US style pattern, and healthy vegetarian pattern, because vegetarian diet can be also unhealthy. So we'll discuss this a bit more. So what fruit? Homer called it the liquid gold. King David posted guards to protect it. Hippocrates called it the great healer. Greek athletes covered their bodies with it. And then in 2023, the price surge now for this fruit due to heat drying up the production of it. So any guesses from people? Well, it's a fruit, not a vegetable. So it's the olive. And it's shown here when it's still raw, and then shown here on the left. And you can see why it's called the liquid gold, because it has a very kind of gold-like quality, but also because it's very valuable. Unfortunately, in 2023, olive oil is going to be, so if you have olive oil, just go get it now before the price goes up further. But the reason this is important is it's part of the Mediterranean diet. And how this came about was there was this 7-country study that many of us have heard about. This is a very old study. Ansel Keys led this study. So if you go to HA Epi or HA in the Epi section, there's an annual Ansel Keys lecture in recognition of his contributions. And his main finding was that they were looking at sort of standard risk factors, and his interest at that time was in cholesterol. So they're looking at cholesterol, shown here on the x-axis, and you can see a range of cholesterol. And for that same cholesterol, they were looking then at CHD mortality rates. And in this case, I'm showing you here the 25-year mortality rates follow-up study. And what they found basically was that the higher the cholesterol, the higher the CHD mortality. Now that comes as no surprise now, but at the time that was actually a discovery. But at the same time, the other interesting thing was that there's a variation. You can see that the lines vary by region. And that's what Ansel Keys noted, that, for example, Japan on the lowest here, as well as Southern Europe on the Mediterranean, some of had the lowest risk of CHD mortality for the same cholesterol. And then if you go to the highest rates, we're actually Northern Europe, the further away from the Mediterranean, and also the US. So that was an interesting observation. It's an ecological study, so you cannot deduce too much from it, but it's an interesting observation. And this was, again, adjusted for some of the other risk factors like age, smoking, and blood pressure. And the Mediterranean is called that way because it's actually from the Latin Mar Mediterraneum, which is sea among lands, and it's shown here. As you can see, it is a sea among lands. It's separated from the Atlantic Ocean about 7 million years ago, and in total, it's about 1 million square mile. But it borders basically Europe on the north, Africa on the south, and then Asia on the east. So it has three continents. But what was interesting about it was that the diet right around the countries that are bordering the Mediterranean, the closer to the Mediterranean that you can get, was really very similar. And it's been noted that that has a lot of benefits. Now, just jumping forward to 2023, you can see that same area has now some of the highest rates, especially the ones in Africa, but also in Asia, in terms of CVD prevalence. This is age standardized. If you look globally, though, you can see the US doesn't do that great, especially in the stroke belt. So the stroke belt will still have a very high CVD. It's yellow, it's not red, so at least that's a good thing. But it's yellow, it's like Russia, for example, or other countries that don't have the same resources we do. And that's really not acceptable. We really need to figure out better ways of addressing this. At least California and Massachusetts are green for now. All right, so what's the data on diet? So first there was this Lyon diet heart study. And this was published like years ago. And this is a follow-up analysis, but basically it was published now more than 20 years ago. And it was a study of about 600 men post-MI, all French. And when the results of the study came out, everybody said, well, it's French, it's France, it's a small study of men in France, and men in post-MI men from France may be very different from the rest of the population. So this study was really ignored for the longest time. But what the study found was very interesting, that they did a randomized comparison of a Western diet, which at the time actually was not really what we were thinking of Western. It's not McDonald's diet. This is a AH or similar. This is an HA step 1 recommended diet at the time. and versus a Mediterranean intervention. And in these 600 post-MI men, they found a dramatic reduction in CHD death or MI, so hard outcome. And in sudden cardiac death, it was actually up to 70% relative risk reduction. But again, people thought, well, we just don't believe this study. It's too quirky, we're not going to believe it. So it kind of got ignored a lot. Until the PREDIMED study, which is another randomized trial, came out now about 10 years ago. And this was in Spain. So that one was France. This is in Spain. And this time they targeted high-risk individuals. So no prior CVD. That one was post-MI. This one was no prior CVD. So these were primary prevention, but they had a lot of risk factors. About 57% were women. They're all from Spain. So they already knew about the Mediterranean diet. They're already taking probably more Mediterranean diet than most of us have, right, currently in the US. And then they randomized them into 3 arms: a control diet, which was actually kind of what's recommended at the time, which is the AHA diet. So that was the control recommended diet. The other 2 arms, Mediterranean diet nuts and Mediterranean diet Evo, had not just nuts and Evo supplementation, but they actually had a very, very intensive dietary intervention where people came in for both individual group session and group sessions. And they came in and were seen by nutritionists, and they had reinforcement of the message, because lifestyle is hard and lifestyle change requires a lot of reinforcement and a lot of, it doesn't have to be necessarily physicians. It was actually in the study mostly done by nutritionists, but nutritionists in Spain are, don't charge as much as they do here. So it was feasible to do the trial. And the Evo was extra virgin olive oil. And it was a lot. So when we did this study in Journal Club, I remember at the time it came out, one of my colleagues said, but this amount of olive oil, how is he going to eat that? I mean, it was like 4 tablespoons a day, pretty much, like 3.5 to 4 tablespoons a day. So he's like, well, he's going to just drink it, But the key thing is that the Evo is actually, as part of the diet. It's not supposed to be just drunk. I mean, who knows? Maybe there is as much benefit, but really as part of the cooking. So for cooking the vegetables or the salads, etc., not really to be eaten with bread, as sort of in the American diet, Evo would be more used. So they basically gave these participants who randomized to Evo, they gave the families, because there was a family and people cook and they eat together. So they gave them about a gallon a month. So it was a lot of Evo. And then the nuts was raw nuts. And it was, half of it was walnuts, which is about 3 walnuts a day. And then the other half was hazelnuts and almonds. So total was about 30 grams of nuts raw and every day. And they were asked to eat it sort of earlier in the day so that they don't eat it late at night after they already eaten their whole meals from the day. But that was the intervention, and both the nut and the Evo arms led to significant reduction in cardiovascular events, as you can see here, by 30%, and the curves start to separate quite early. And what's interesting is that this population, you may ask, well, how many were on statins? But a lot of them were on statins. This is a high-risk primary prevention population. About 50% or so were on statins. And they actually had, if you look at their risk factor profile, they had pretty good control of their other cardiovascular risk factors. So this is on top of statins or the other prevention treatments people get. And what's key here is the compliance. So some additional analysis, you may wonder, well, how compliant do I need to be with the Mediterranean diet? Remember, this is a Spanish group, so they already know what's Mediterranean diet. They were just getting reinforced as to how to increase those same components in their diet. And what they found was even just a 2-point difference made basically correlated with the benefit. So on average, the control group was 2 points less on this 14-point adherence score compared to the intervention groups. And that 2-point difference made a reduction of 30%, which, just to remind you, is very similar to the benefit you get with statins. But this was on top of it. Then there was another study, CardioPrev, which just came out recently, about a year ago. This was also in Spain, but this time it was secondary prevention. And it was 1,000 people. All of them had prior CHD. They were mostly men, had about 7-year follow-up. As you can see here, there was again a reduction about 27% reduction in cardiovascular events over the period of about 7 years. So now we have like three randomized trials. Now they were all done in Europe, and in fact we tried to get the trial to be sponsored by NIH here in the U.S., but it's too expensive really to do on large scale for outcomes. But we also wanted to know what are potential mechanisms that may mediate this benefit of the Mediterranean diet, because there are many components to the diet, and which mechanisms are involved. And this work was done mostly led by Shafkat Ahmed, who's was a postdoc fellow working with me, and now is actually in Sweden. And what we wanted to know, there are many potential benefits for Mediterranean diet on many pathways that are related to cardiovascular disease, including inflammation, diabetes, insulin resistance, blood pressure, lipoprotein pathways, obesity, adiposity. So these all potential mechanisms that could influence CVD risk by improvements with the Mediterranean diet. What's notable about the Mediterranean diet is it actually does not result in lowering LDL cholesterol or total cholesterol. So if you check those for patients, it would be basically not much change to whether or not they're on the diet or not, or how compliant they are. But we looked at other pathways that we could try to get from, in this case, we did NMR spectroscopy. It's kind of like now people are more familiar with the Nightingale NMR spectroscopy metabolomics panel that just got done on the UK Biobank. But this is very similar. It gives you kind of all kind of detailed metabolites. We also had some other biomarkers measured through standard assays, ELISAs, et cetera. So we looked at various different pathways. And we wanted to see how is the benefit, and so using mediation analysis, we identified that a lot of the benefit, although there were multiple pathways involved, a lot of it was related to inflammation, insulin resistance, adiposity, and blood pressure, with some effect from lipids, but for the lipids, it wasn't the total and LDL cholesterol, it was more the triglycerides pathway and HDL, as opposed to the LDL pathway. And so what we also identified is we were trying to look at diabetes risk, not just cardiovascular disease risk. And we identified that the biggest benefit there was for improving insulin resistance, for changes in insulin resistance parameters. But of course, also multiple pathways are involved. So not just one particular pathway is affected by this diet. And insulin resistance, as measured in this case by the NMR panel, basically relates to many things, including many pathways: inflammation, lipids, lipoproteins, post-translational glycosylation. So many pathways are related to this. And of note, we also found in another study led by Sagar Dugani, who's at Mayo Clinic, who was also a resident with us at the Brigham, but we identified that this lipoprotein insulin resistance is the strongest risk factor for premature coronary events in women. We used data here from a women's health study, and we were comparing, again, the same kind of panel biomarkers. And what we found was that this lipoprotein insulin resistance is the biggest impact for premature coronary events. So again, that this Mediterranean diet is acting through pathways that aren't related to the traditional LDL cholesterol, HDL cholesterol, LDL cholesterol, total cholesterol, but mostly to inflammation and other pathways related to insulin resistance as well that are very important. Then we took another step. We were also interested in physical activity. Remember from that study that I showed you, physical activity is a bit better than diet in terms of the US prevalence of inactivity, but it's also hard to get our patients to become more physically active. And we also wanted to know, like, when you're talking to the patient, sometimes you want to explain to them like why this has benefit, and telling them this may like lower your risk of cardiovascular disease by 20%, 20 years down the road may not be as convincing to a patient. But if you can tell them, oh, well, this may improve your blood pressure, may improve your inflammation, or because again, the standard effects aren't so much on LDL cholesterol and pathways. So just briefly, a historical perspective, if you go back, the health benefits of activity have been known for a very, very long time. In fact, actually for, around 25,000 BCE, the Chinese physicians advocated Kung Fu as a way to avoid illness. So that was a preventive approach to avoid illness. Subsequently, several thousand years later, Hippocrates also said, his famous quote, to keep well, avoid too much food and too little toil. And just as a reminder, in the ancient Olympic Games, the winners were only awarded an olive branch wreath because physical fitness was seen as its own reward, and athletes were really celebrated in the ancient Greek culture. So in this work with Aimin Lee, using also data from the Women's Health Study, which is a long-term study ongoing at the Brigham for now over 30 years. But at this time, we had about 11-year follow-up. And we looked at women self-reporting physical activity. So most of these women were nurses. They were healthcare professionals for the most part. They were nurses, some doctors, some other healthcare providers. And we found that, and so self-report is good. It's been validated, the physical activity by self-report in this group. And what we found was that women who were couch potatoes, which is the reference, less than 200 kilocalories a week is really a couch potato. If you go from going couch potato to like basically 200 kilocalories a week, you have the biggest benefit of physical. And this has actually been documented in many studies. So that's the biggest benefit. But you get additional benefit with up to 40%. In some studies, if you go more than, in this case, we group them at the top level as more than, because 1,500 kilocalories per week is the recommended guideline recommendation for how much to do. But if you did more, there was additional benefit. In other studies, meta-analyses, we know that there's benefit for up to about 4 or 5 times the recommended activity level. But if you go beyond that, there's really no, and maybe potentially harm if you go to extreme levels. But basically the biggest benefit is here, going from nothing to something. So that's always something I like to advise my patients, because often our patients are in that category. And so we also look to see about the benefits. So how does physical activity, help to improve cardiovascular health, cardiometabolic health? And we found we were able to explain about 60% of the benefit of physical activity using the risk factors that we had in the study. And in particular, again, using a mediation analysis, we found that inflammation was a key factor. And blood pressure and lipids were lower down, and BMI was actually even much lower down to only 10%. So I use this often to motivate my patients that, look, even if you don't lose weight, you can still get benefit, because it's going to improve your inflammatory profile, improve your blood pressure, and even small changes over time accumulate. And the same thing with the Mediterranean diet or other healthy diet. It's really small changes accumulate over time. We even know that from LDL cholesterol, right? Because LDL cholesterol, we also know that it's a life exposure to it. And the same with these, it's really a lifetime exposure to these. But now with the more precision-based approaches, we can even take a deeper dive. And in this study led by Rosangela Hoshi, one of our Brazilian postdoc fellows on the Lehman Fellowship, working also with Yan Liu and Olga Demler from our division. And we identified that physical activity has many more effects than just what I just showed you on the last slide, but it actually really changes the whole bioactive lipidome. And the bioactive lipidome includes markers such as metabolites of fatty acids, such as EPA and DHA. It also includes things like the specialized pro-resolving mediators, SPMs, that are known to be anti-inflammatory and inflammation resolution. So both, not just anti-inflammatory, but also resolve inflammation in the coronary arteries. And we found a lot of changes. In fact, we actually found about several hundred of them that changed with physical activity. We replicated that. This was using mass spectrometry assay with our colleague Mohit Jain at UC San Diego, and also with Susan Chang, who was there at the time. And we also identified some of those biomarkers that then also related to cardiovascular benefit of physical activity. And we were able to replicate that. Now, the question is that we don't know what they are. A lot of these molecules, we know they're bioactive lipid signaling molecules that are important in immune function and in inflammatory signaling and other pathways related to cardiovascular disease, but the exact specific identification of them is a bigger question. And that's one of the, with this metabolomics, that's one of the limitations currently, is this dark matter, that you can identify there's something there, but then you don't know what it is exactly. And identifying it is really a dark matter because it's hard to identify. NMR and quantum computers may be able to help us, actually. We definitely need here higher, because it's like a very, very slow process. We collaborated briefly with the physics department at Harvard with Dries Sells and Eugene Demler, and we identified that NMR could be a potential way to basically have the signals from the NMR be fed into a potential quantum computer that could then potentially quickly identify. But here, we just show proof of principle that you could do potentially an algorithm that includes in it quantum computing would actually give you a faster and more an ability to actually solve for the molecular structure of these agents that you're identifying. Lipid and metabolic signatures of risk, we also wanted to look more at an individual. So again, this is more like precision medicine, looking at an individual's profile for lipids and lipoproteins, and we're using metabolomic technologies as well. And can we identify, more precise risk assessment for them? So we utilized the Jupiter study, which is, as we know, a randomized trial funded by AstraZeneca that compared rosuvastatin high intensity with placebo among individuals who had high C-reactive protein, so chronic inflammation, but low LDL cholesterol. These were primary prevention individuals. And we know there was a benefit of about 40% reduction in cardiovascular events over about a 5-year period in the Jupiter study. But what we wanted to know is there are still people, even on rosuvastatin 20, and these are primary prevention, they often had their other risk factors well controlled, but why are they still having events, And so we wanted to see if we can identify this residual risk phenotype by looking at things other than just LDL cholesterol reduction. And with Patrick Lawler, who's actually now faculty at University of Toronto, when he was with us, he examined in more detail the lipoprotein. In this case, we also leveraged the NMR NMR profile to look more detail at the lipoprotein profile. And what we found was that there's a lot of variation, especially in the VLDL or triglyceride-rich lipoproteins that gets is not very, as you can see here, the bars, the standard deviation bars are really quite varied. So there's a lot of variation among people who go on a statin. And then we try to identify which of them could matter for cardiovascular risk. So, so a lot of things are changing with the statin, but which ones matter, other than we know LDL cholesterol matters. So what we found was triglycerides did not really matter. It's actually the risk of people who went on a high-intensity statin who had above average or below average reduction in their triglycerides didn't affect their risk. So compared to people with placebo, which is the dot here, the circle. But what we found was that if you looked in more detail on the phenotyping, that there were particular particles, especially the small VLDL, so small triglyceride-rich lipoproteins, that there was a very definite dose response, so that people who had more reduction in their VLDL had associated lower risk of events. And that was in addition to the LDL cholesterol reduction. So again, just as a kind of a proof that maybe you could find something that you could pursue further by this individualizing risk. Here, and these are waterfall plots. You can see each basically vertical line is a person, and you can see some people had increase in these particles, and some people had decrease in them, which is the blue. And trying to show you here that the people that had more of a decrease, which had more of the blue, these are the ones that had fewer events during follow-up. Compare that, for example, to larger triglyceride-rich lipoprotein particles, where even though people who had reduction in them with statin did have reduction in events, but there was no dose response. So it was similar whether you had a little bit or a big reduction in them, suggesting that this is probably not causal. If anything, maybe more the smaller VLDL particles were more closely related to risk. And then we confirmed it with another technique with ion mobility, which is another high throughput way to characterize lipoprotein particles. And again, using like an orthogonal technique, we found the same thing, that these like smaller to medium-sized triglyceride-rich lipoprotein particles mattered for cardiovascular risk. And that was independent of the other LDL cholesterol as well as the other risk factors. And now we're exploring it further, like more in depth. So Rosangela Hoshu, I showed you the data that she presents. She's actually presenting this data at the AHA. I put it at the bottom there, November 11. If you're around, go to her. She's a young investigator finalist at 3:15 to 4:30. She's presenting this data. So she now is interested in looking at the whole bioactive lipidome. We measured it again in collaboration with Mohit Jain and the team at UC San Diego. And we examined how does a high intensity statin compared to placebo over a 1-year period, how does that result in change in your bioactive lipidome? And we found like tremendous changes here. I mean, you can see them, all the gray dots are ones that change, but that we don't know what they are. So you can see how this dark matter in metabolomics is really quite extensive. And that's what we need help with, identifying all of these. And standard approaches don't work because they're extremely tedious. But the named ones, the ones that have quotative annotations here are shown. And you can see there across the spectrum of, like say, arachidonic acid, for example, was reduced. If you have any favorites here, but some of these metabolites are from both arachidonic acid pathway, and some of them are also from, say, EPA pathway. Here you have di-HDPA from the EPA pathway. And these were changed by the statin compared to placebo, so in a randomized comparison. So basically, the last part of this talk will be aspirin. I'll try to highlight some of the shared decision-making, individualizing risk versus polypill. So again, aspirin has been ancient. I'm taking you, I guess, a lot to the Mediterranean region, partly maybe because I'm from there originally. And I know in the news now, it's been really sad to see what's happening. But aspirin has actually been known by ancient physicians. This is, for example, in the Ebers papyrus. It was named Ebers after the discoverer, who was Ebers. But the papyrus is Egyptian. It was also noted on the Sumerian tablets, so in stone, which is what Sumeria at that time was in Mesopotamia. So ancient physicians and healthcare providers at that time knew that aspirin, in the form of the bark or the leaves of the willow tree, shown here, it's a willow tree, that actually had benefit for inflammation reduction and also for analgesic purposes. So even back then, but over the past 3,500 years, we still, are unclear what to do with aspirin, even though, in 3,500, you'd think we'd make some progress. And we did. We manufactured aspirin in 1899. It got manufactured. But this is, for example, from Roger Blumenthal, who presented the ACCHA 2019 guidelines. This were the hashtags for the aspirin part of the guidelines. When it comes to aspirin, I don't know anymore, where aspirin and primary prevention is complicated. Now, why is it complicated? Well, what we do know, the data is actually very clear. So the data in primary prevention is that we know aspirin reduces cardiovascular events, in particular the non-fatal ones, MI, for example, by about 15%, stroke by, again, about 15 to 20%. And those are reduced. Mortality is not reduced for CVD death. So, and the reason it's not most likely in primary prevention is because these trials are short. They're 5-year trials. So you take a healthy population, generally healthy, that's, and you follow them up for 5 years. So you do reduce MI and stroke. So you can anticipate that if you had longer follow-up, you would also reduce more cardiovascular mortality, because we know cardiovascular mortality is related to non-fatal events, MI and stroke. But the trials are too short, and the people are too healthy. People who are volunteering to these trials or get in and get followed, and generally their risk has actually been on average quite low. If you do like the Framingham risk score, if you do the PCE risk score on them. And then the other thing is that, you can think of crossover too. If you're in this trial, your prime prevention, you get put on the placebo and you get an event like MI or stroke, you're going to go on aspirin if it's a non-fatal event. So then there's also crossover. So that's part of the reason why it's complicated in primary prevention. And by the way, this data is all for low dose aspirin because most of the trials have been on low dose, and high dose does not have any additional benefit. It just increases risk of bleeding. So we do know this. This is actually from just one meta-analysis, but several meta-analyses show the same thing. And this actually includes in it the latest trials that came out that were, two of them were really underpowered, Esprit and Arrive were underpowered. And Ascend, the one from the diabetes from the Oxford group, was actually significant reduction in diabetic patients. But you can see here on the counter side that there's bleeding, right? And that's why this is tricky, because you take a primary prevention, you first do no harm, right? So you don't want to cause a major bleed or have at least 50% chance of increasing major bleed if there's no, if that person is low risk for cardiovascular disease. And that's why this comes in, because there is a risk that's a definite risk, 50%. But at the same time, there's a reduction for cardiovascular events of about 15 to 20%. But it's not for fatal events. And so the USPSTF updated their recommendations. And what they said is they did a microsimulation model that was very complicated. But if you basically read their what they did is they decided that colorectal cancer benefit was no longer. In the 2016, using the same data, by the way. So this goes to show you that how one guideline committee or recommendation committee could come up with this completely different based on just, even though the data really did not change. I mean, including the 3 studies that were published in between did not really change the equation. It's just that they decided, to have different assumptions in the models. And the one assumption that they removed was the benefit for colorectal cancer, which one could argue with, just because there is data and there's an ongoing trial as well now. So we'll know more, but one could argue there actually is a benefit for colorectal cancer, but it just takes years to see that benefit. So anyway, they just gave blanket recommendations if you're basically between age 40 and 59 that you can individualize the risk. Now, I do agree with individualizing the risk for primary prevention for aspirin, but I'm not necessarily sure I would restrict it to 59 because a lot of the data from 60 to 69 is also, this shows benefit. And the bleeding risk up to age about 70 is reasonable. It's just once you get over age 70, the risk increases exponentially with aspirin. And that's why the concern over bleeding and the Esprit trial showed increased risk of bleeding, especially with older individuals. Other guidelines like the 2019 ACC/AHA say if you're at higher risk for ASCVD, but not at increased risk of bleeding. So they didn't give us much guidelines, right? Because, yes, okay, sure, that makes sense, but tell me what's higher risk. And they wouldn't tell us what's higher risk. They kind of left it to us to interpret what's higher risk. And they also kept it up to us to decide what's increased bleeding. So that's often not very helpful. And the reason they did that, though, is because they didn't know. It's just not really clear. And then the European guidelines, which all along, actually, for the past 20 years have been saying do not use aspirin in primary prevention. But then after the Ascend trial came out, that was the Oxford group run aspirin in diabetic patients, and they found benefit by about, again, 20% reduction in vascular events. So they actually changed their guidelines now more towards the American guidelines, which is they may use, may consider low dose aspirin if you're, high risk. So they're saying diabetes and either high or very high CVD risk as well. So they're trying to, again, and all of these are class 2B indications because it's, it's not really, because of the risk, not so much because the benefit is clear, but it's just that the risk. The ADA guidelines, again, sort of trying to restrict it to those who have ASCVD or PAD, or higher risk than average patients with diabetes. So this was an opportunity actually with Joanne Manson and Jeffrey Ames. We decided, this was a while back now, we decided to individualize the risk, but doing it through an app so that it's easier because, we're cardiologists. So for us to assess cardiovascular risk is relatively easy, although that takes time. But to assess bleeding risk is harder. And you have to do it in order to individualize risk. You really have to be able to calculate both and then to weigh the risks and benefits. So the app does that. It calculates the risk for both CVD and also for bleeding. And then we do provide recommendations. So these recommendations were revised after the 2020 to a USPSTF guidelines, but recommendations. But we did do some changes, which is 40 to 59 is what they recommend. But we have the additional thing, which is calculate their NNT and NNH, number needed to treat, number needed to harm. And for that, you have to have a calculator to be able to assess their absolute risk, and therefore what's the NNT and NNH for that person. And then if the benefit is more than the harm, then consider aspirin. So that's one additional step for individualizing the risk. But if you're 60 to 60, we said if over 70, I think by now all the guidelines agree that you should not start aspirin for prime prevention. Now it's another question if you should stop it if you've been on it for a while. That's even more unclear. But if you're 60 to 69, since a lot of the patients in the trials, in particular, say the Women's Health Study, that was the age group that they found benefit for stroke reduction, ischemic stroke reduction. But also, that's where the risk for men and women increases as well. So we thought it was reasonable that, again, going with the European guidelines, if they have diabetes and have increased, risk, so therefore they would have NNT less than NNH, consider aspirin, or if they have a 10-year ASCVD risk more than 20%. But again, you have to calculate NNT, NNH, and that one you need a calculator for, and that's how if you don't want to individualize risk, but you want to take more of a population level, the TIPS 3 did that. That was a polypill trial, and polypill, it was actually 3 arms: placebo, polypill, and then aspirin, so both. So it was like 4 arms, 2 by 2 factorial. And you can see here that the polypill with aspirin did the best. That's the green line here. You can see aspirin alone versus polypill alone, kind of the 2 graphs almost overlap completely. And then you can see here double placebo is obviously the highest risk. This study was done in a high-risk population in India, and where maybe you want to take a population level approach, potentially. The polypill had several antihypertensive medications, such as like an ACE inhibitor, a beta blocker, also had a statin. I think it also had hydrochlorothiazide. By the way, there has been a secondary prevention trial, that was led by Val Fuster. And aspirin was also part of their polypill, but that was secondary prevention, and that was also benefit. There was benefit was included. Now here, the nice thing is that they actually had an arm that was aspirin arm, so you could examine the additional benefit of having aspirin. And this one is prime prevention. The other one was secondary prevention. So today's objectives, I hope I have shown you that there's really a lot of challenges remaining for ASCVD prevention, whether in the US or globally, that we need both population health approaches and precision, more individualized approaches. And the field is really emerging. While we discuss topics that were really common and that are, we deal with every day, but this field is really emerging and very exciting for people who want to make their career in this. Some take-home messages, especially for clinical practice, that of course there's a changing epidemiology of ASCVD, yet we know that the CVD and the risk factors for CVD remain the top causes of death. Lifestyle improvement is one of the most important components of prevention, and new approaches are really required for both population health and for more precision, individualizing health assessments. And finally, just these are some of you can't do this kind of work without having really a whole tribe of people, and that's probably now true for almost any field in research. And I want to thank the funders, of course, the NIH, and happy to take any questions and comments from you. Thank you.
Right, well, thank you again for coming out. This is our first hybrid experience, and it's been tremendous, large part due to you.
Thank you.
So we do actually have a couple questions in the chat. We can get to those, and then any questions in the room. I know we're at 1 p.m., so acknowledge that some people may have to go. But I think Dr. Lee, are you there? I think you may still be there. He had a question, Sean, from last night.
Yeah, thank you. I just have a quick question. When you showed the slide for Predimed, I just, thinking about how early those curves separated, do you think that's consistent with what we expect from like an effect, a dietary effect on cardiovascular disease?
Yeah. So what Sean noticed is that the curves separate quite early. In fact, actually, if you did a statin trial in that same population, it would take about a year before the curves separate. So here they separated really quite early. And I think that is because, there we go. I mean, even in the CardioPrev, they separate, they start to separate early. There's here a little bit of, they come back together, but mostly they even start, this is 1 year. So even they start after a few months. CardioPrev was secondary prevention. Predimed, I think they separate early because as I showed you, so the Mediterranean diet has effects on things other than LDL cholesterol pathway. If it was just an LDL cholesterol pathway, it would not separate so early. But inflammation, for example, can change very quickly. I mean, and the other pathways like insulin resistance, where's that slide? But anyway, all these pathways where diet can influence cardiometabolic risk. So yes, it is a notable finding. But it's consistent with the literature. In the Leonhardt study also, it was almost immediate benefit for the diet. And these are interventions. So there's no other thing to explain it. It's the intervention because it's a randomized, control. You could argue it's not really fully blinded, but, but still we're dealing with hard outcomes. So.
Great, thank you.
Thank you for the question, Sean.
And Dr. Dillon, we can see you on the big screen up here, and I know that you had a question as well.
Yes. So first of all, thank you for the great talk. I was just curious about your opinion about keto diet and data, I think that was presented at the ACC in UK Biobank showing increased cardiovascular mortality with this diet.
Yeah, I mean, so in general, the only diet that has randomized trial evidence is the Mediterranean diet. And everything else for all the other diets is observational data, or it's like very short-term studies where all you can look at in short-term studies is you can look at just like surrogate markers. And we all know the problems with surrogate markers. So, so for benefit, for benefit, the only thing we have is really the Mediterranean diet. And that's why I highlighted it. All the other, problem is with observational studies and observational analyses, there's always confounding. And diet is one of the ones that's like horrendously, notable for all the confounding that happens because people don't just eat one thing. They eat like, okay, I eat more of this, but then that means I eat less of this. And in fact, actually, that's why the AHA, I think, guidelines for diet ended up, wrong at that time because they ended up, even though they said less fat, but then they end up, what people had in the end was more carbs. And so that's what happened. And, yeah, I agree with you about potential risks, but again, without any randomized trial data, really, that's why I emphasize more the Mediterranean diet. And anything else with other studies is going to be due to, going to be heavily influenced or biased by confounding and by the people who change their habits in order to get something or another. Yeah.
Thank you.
Any other questions in the room?
Hey, great talk. I'm Ato Kasan. I'm the program director for the fellowship, and I'm a non-invasive cardiologist. I was wondering if you could talk a little bit about ultra-processed foods and the data behind those, and given how prevalent they are in food and stuff we're eating now, and their association with inflammation and just the addictive nature of a lot of them in our food sources. It's not all types of carbs and, foods are created equal.
Yeah, I mean, ultra processed, again, the data is really from observational. So just, again, just keeping in mind that observational dietary data is just like the hardest to interpret because diet is so confounded by so many things. But yeah, I mean, based on, again, observational data, it does seem that they are, ultra processed foods is actually, detrimental. But again, it's all based on, it's not really based on, no, there are a lot of ongoing efforts to evaluate it further through larger studies, but none that I know for doing randomized trials. But the observational data, again, is as the prior question also was about, like, there's increased risk. But again, you're looking at surrogate markers and you're looking at observational studies. So the level of data is weak, but yeah. That's why I agree with you. There is risk to all these things, and so that's why the key thing is, both Predimed and all that is sort of like you just need 2-step improvement in your Mediterranean diet score, and you get 30% benefit. So, if you go from 0 to 14, you're gonna live forever. But if you do just 2 points better, so what's asking us to do is more of what we know is good for us, and just do it a bit more and a bit more consistently.
I feel like a lot of it is behavioral when you talk to patients, and kind of this addictive nature of certain types of food that we have processed food in this country a lot more. I wonder if that's part of it. The difference for the reason when you compare us to other countries.
I mean, there's and there's even data, even the Mediterranean diet itself, that that studies from more like in the US show that there's potentially a bit less benefit than, say, the Mediterranean diet in Europe or Mediterranean countries. But I think the key thing is to and this is true not just for diet in CVD, but it's also for physical activity, for any of the behavioral changes. It's like, just do, if we can get patients, and I showed that for physical activity, if you go from couch potato to 200 calories a week, you've already 27%, you're already most of the benefit. I mean, you can always get better, right? But if we can get them to improve, if we can get ourselves to improve just a bit, there's going to be added benefit. If you are able to maintain that, not just for a week or two, but if you're able to maintain it. So in order to have change, behavioral change has to be, it has to be really not just shared decision making, but it has to be really, there's many factors that go into it. And most important is probably reinforcement. But there's studies showing that even as a cardiologist, if you ask somebody and you reinforce them, that it will affect their behavior. But of course, more like other approaches such as nutrition, and that's why you need that's why I think that's where you go to public health. Then you need policies, you need even things like what New York did, where you make it hard for people to get certain, say, trans fats, so they move that from the diet with a law, right? It wasn't like a doctor telling. I mean, you could tell that patients all you want, but if the law is not available, it's not available.
Well, in the same vein, the slide you showed of the pyramid, I mean, we should be really trying to do our policies in that primordial layer, right?
Absolutely. And that's the hardest layer. That's the hardest layer. And maybe not all of us are inclined that way, but we need somebody needs to address those. Yeah. Because you saw the CVD death rates, the CVD problem.
You can't get rid of these.
Already, I know things on
Samia, I have a general question. As a preventive cardiologist, looking to improve our models of prevention and improve our data and how we treat patients and personalize our care, you're showing us how these models are going to define our prediction of the future, right? Not so much randomized controlled trials. What would you recommend to us as cardiologists that we start measuring in our patients and putting in our notes or getting markers?
Yeah, that's a really that's a difficult question to answer, because yes, I think I would say there's even a lot we already know that we don't incorporate. I think I would start with that. And I think that's where EHR could be really helpful. You have to always avoid some of the over notification or whatever that's called. But in addition, but even things say aspirin. Like, for example, we tried to get our aspirin guide as an Epic, but it would end up charging us a lot of money. We don't have funding from industry, so we decided not to pursue it. But something like that, where somebody could just pop up to you and tell you, okay, this person, for example, how they pop up and tell you this person's due for their colonoscopy or their mammogram or whatever, and you just want something that so that could be anything that's more automated is helpful, especially for risk. Because prevention is about risk, a lot of it. And risk, you cannot estimate it. I mean, even the best clinician, I can tell you this person's high risk or low risk, but once it gets into all the finer, is it 11%, is it 10%? What's short-term versus long-term? If you're younger, the data for younger people is even harder, because if you're younger or a woman, you have to be about 70 before your risk becomes at the level where you can actually, meet the HA criteria for 7.5% or higher. So a lot of people, who are younger and who are don't meet the standard criteria, but they're still at increased risk because their lifetime risk is going to be high. So we need these, I guess I guess maybe something like where alerts can come in, but in a way that doesn't overwhelm clinicians, but at least for the things that we know benefit people. But I think also it needs to be, I mean, measuring things is great, but a lot of times you need to know what to do with it. And I think that's where the tension is as clinicians. Like, yeah, I love some of the stuff, like say the small VLDL, like maybe I would get it measured, but like, I mean, what would I do with it? So you need to know what would you do with it? If it's just for risk assessment is one thing, but also if it's for something like acting on it is a different thing. I think the acting on it, that you need a lot more research and understanding of how to fit it in clinically. But I think even the basic stuff we often don't do. And then you need for lifestyle, you need a system for that. Like for example, like people can't walk if there's no sidewalk. People can't walk if there's no green space. We know green space correlates with social determinants of health. These things are like more on a policy. So I do think ultimately it has to be a lot of it has to be policy. But also there's a lot at the individual level. We can encourage people that like, look, even a 1 or 2 degree change, and it could be the 90-10% rule, or the like maybe now you ate a cookie, but you won't eat one for like the rest of the week, kind of thing, where you try to emphasize the continuous, the risk. It's a risk spectrum. So
do you think that at some point we are going to incorporate social determinants of health in our risk assessment?
I mean, it can be easily done. Like even like they've done studies showing zip code is like it's like better predictor than almost anything else.
The ASCVD risk at point.
Why doesn't it include zip code?
Or zip code.
I mean, zip code is a strong predictor of risk. Yeah. I think something like that could be done with an electronic healthcare record. Yeah. Yeah, it's not just risk for cardiovascular disease, it's risk for like all kinds of bad outcomes. Yeah, but the problem is people often can't change their zip code. I mean, those who can, then they're already low risk often, So, yeah, these are really important issues. I mean, I think that's why you get that yellow, that whole southeast of the U.S. That's all like yellow, same risk as people in Russia who are like smoking and drinking and God knows, So, but you have the same, you have just as high prevalence. It's just like here and that belt is more maybe stroke rather than coronary events as well. Yeah, but I think we do need that's why we need new approaches. We need also more funding for interventions and for new approaches. Yeah, but thank you very much. I really appreciate all the.
Thank you, Dr. Mora.
Sure, thank you. It was really an honor.